morning, everyone. My name is Chris Kiblin. I am the host of the Suited Warrior podcast. I hope you're having a fantastic day. We're in the beautiful studio of Preferred Shore in downtown Sarasota. So thank you, Robert, for allowing us to use your podcast. And as always, I'm always suited up with tweeds, custom suits. So if you ever need a suit, please go over and see Don or Rob right in downtown Sarasota, and they can hook you up. So today we have a very special guest in the house, and because it is Breast Cancer Awareness Month, I thought I'd have somebody who can actually really contribute to what it's like to go through breast cancer. And I am also a ambassador for Men Wear Pink, so we are looking for donations. I will actually have that in the link below in the comments when this all gets published, so you can click on that link and you can donate. So I have Dr. James Kotick, who is actually probably one of my good friends that I've met, ironically, at the gym. And we met, I don't know, 4 or 5 years ago, probably. And so working out, and I got to know Dr. Kotick over the years. And he actually did a little bit of stuff for me. And then, but I come to find out that he is very involved in breast cancer, and it's probably the majority of his practice of what he does. And I'll let him explain all that to you. Welcome, James. How are you?
All right. Thank you so much, Chris. Thanks for having me. My name is James Kotick. I'm the plastic and reconstructive surgeon of Envision Plastic Surgery here in Sarasota. A little bit about my background. I was born in Florida, trained most of my life in Florida. School in Tampa, medical school in Miami, general and trauma surgery in Orlando, and then a few years of fellowship in plastic and reconstructive surgery in Boston. We really focused on the cutting edge for breast cancer reconstruction. I was recruited pretty heavily to come to this area to bring the advanced reconstruction to this area, as there really wasn't much between kind of the SMH and Tampa area to kind of fill in the gap. So that is, as you said, the bulk of my practice, breast cancer reconstruction. And one thing I find is that there's not a lot of education out there, and people are kind of overwhelmed when they hear that diagnosis. The prevalence of the disease is actually increasing, especially in younger individuals. Everyone knows someone that's been affected. There's probably 1 in 8 women that are affected at some point in their life, and the incidence of women under 50 being affected has actually increased to about 1.4% per year, which is increasing faster than the other demographics. And so early screening is going to be pretty critical.
Okay. So let's kind of go back and talk about a little bit about you, and then we'll get into the breast cancer part of it. So, one of the things I always like to ask my guests and everything else is, what made you go into wanting to become a doctor, and then also start getting into this type of field?
It's a great question. So I was always interested in the sciences and the arts, and really wasn't sure when I went to undergrad what I wanted to do. Went through undergrad, was working in a lab doing human tissue samples for Alzheimer's disease, and I was planning on doing a PhD type of research, and that being my future. Had to collect samples from a neurosurgeon over at Tampa General, and fell in love with being in the OR under the microscope there so much more than in the lab. So that kind of shifted things for me, caused me to pursue a career in medicine. Initially applied as a MD PhD, ended up proceeding with a MD M.B.A, finished that, and then proceeded. I kind of considered all forms of surgery, decided amongst general because it had the greatest variety for me. Hadn't really been exposed to plastic and reconstructive surgery. So during my general surgery career at a level 1 trauma center, I found that the plastic surgeons were doing such great things for reconstruction and restoring form and function that kind of inspired me to continue my training in plastic surgery.
So how long were you doing general surgery for?
For 5 years.
5 years. So, and then that kind of, as you started doing that and started seeing more of that, you started seeing, like, this is really where I want to take my career, and really started focusing on the plastic surgery to help with women and reconstruction surgery and that kind of thing.
Absolutely.
Okay. And so as we go through that part, I know from just knowing you from the past, you did work for someone, right? And you just recently opened up your own company. correct?
That's correct. When I was kind of recruited to this area, it was kind of under a private equity umbrella, and they kind of sponsored a group of 3 surgeons. We parted ways equitably and still have a fantastic relationship. And I separated from that group and started my own practice because I wanted to be able to provide even more care to my patients without kind of corporate world interfering with what I could offer to patients.
Right. So, and then you moved into a beautiful office in Waterside. So if anybody that lives in this area or is around this area, Waterside is just growing tremendously. And your office there is just absolutely gorgeous.
Thank you.
I mean, so, and when did you take over that spot?
About 2 years ago, coming up on the anniversary this month.
Okay.
So, yeah, it's worked out well for us.
Now, are you the only plastic surgeon in your office, or do
I am.
You are, so you're the only doctor?
I am.
Okay, so you keep busy because I know you're always running around. I know you got
So true.
A family, and you got, is it 2 girls?
2 boys.
2 boys.
Yep.
See, I knew it was 2, so I couldn't remember which one. And recently, not too long ago, right?
Yeah. So I've got a wife and a 3-year-old and an 8-month-old, and then we're working on doing another round of IVF, which has been a challenge.
Gotcha.
But all of our children are through IVF.
Oh, okay, gotcha. Did not know that. So you did learn something new every day. So, okay, so that, and one of the things that we like to talk about is, because, I mean, most of the people that I have on my podcast are business owners. And so, that's a tough challenge. I mean, you are sitting here. I know we talked about going to the gym, how hard it is for you just to get to the gym sometimes. But like as being, okay, now you got to be a husband, a dad, a business owner, running business, taking care of all this, because I mean, you got to see the patients, you got to do surgery. How do you manage to juggle all that into your daily life?
Yeah, that is the real question, isn't it? And I think it's prioritizing what's important. And, my family supports that. And during the business hours, I leave before everybody's awake. I get there, I do what I need to do for the patients. And then end of day, it's family time. And then when they all go to bed is when I finish up all the paperwork and everything else. I mean, you're a business owner yourself. You get how it is, not enough hours in a day. But when you want it enough and when it's important enough, you make it happen.
Yeah, it's one of the things I always said is, especially sometimes especially if you love what you do and you feel like, especially if it's giving back to do whatever you're doing, that passion that's there, a lot of times it doesn't feel like work. It doesn't feel like you're sitting there, you're doing something with a purpose. And, and that's how I've gotten through it. I mean, my job is 7 days a week. I mean, I could be getting a phone call at 7:00 at night. On a Saturday, and and a lot of times I have to answer it, and so it's not always easy. It does make it difficult. So like trying to juggle everything and trying to manage that business, but then also manage your personal life. It's hard. I mean, it's very difficult. And a lot of people, when I talk to people who want to become business owners or are business owners, you really do have to realize that you've got to have someone, whoever that significant other is in your life, they have to have an understanding of, this is my life. This is what I need to do in order to grow my company or work on building my company, because it takes a lot of hours. I mean, and
Correct.
You have employees that are counting on you. You have other people that are counting on you, and, depending on whether or not your spouse or significant other is working and they're taking care of the kids, then they're home, and then they're want you to support them. So like, there's a lot to juggle when it comes to that, and then you're just like, okay, and you're right. You never feel like there's enough time in the day. I mean, I get up, 5:00 in the morning, and there's many nights I'm working until 11:00 at night.
Sure.
Because I might be out doing this or being out on appointments or whatever during the day. Well, then I got to go home and work, and actually got to follow up with clients, follow up with stuff. So it's not easy trying to multitask and do everything and be everywhere. So I can only imagine what it's like for you, because I mean, with surgeries and your planning days and that kind of thing, and just trying to divide your time equally, it can get exhausting.
Yeah, it's true. Surgery, I don't want to come off the wrong way, is actually the easy part.
Oh,
Because
really?
the world becomes quiet,
Oh, okay.
right? The distractions are gone, the phone's set aside, and you actually get to focus on what you're doing for a little bit. And then you come back to reality and have to catch up with everything. So it's kind of this roller coaster up and down. But as you said, taking time to take the priority and what's important and realizing it's a return on investment, realizing that, yes, the first few years are going to be very, very difficult, but building the strong foundation is the most critical part. If you take the shortcuts early, you're not going to have a good foundation. It's going to collapse later on. If you take the time now, build what you need to, create the infrastructure, create the processes that are going to make everything flow, then later on you get to relax and you've got something to kind of fall back on. And the biggest difference working for myself rather than working for corporate is they're my headaches.
Right. You know, that's true.
I get to make the decisions, my risk, my reward, but also I get to sleep at night knowing that I've done the best I can for my family, for myself, for my patients. Whereas when you are employed, you don't always get to make those decisions the way you want to.
Right. So I get that. So, so now we're going back. Let's just jump back into your everyday life of work. Walk me through what a typical work day looks like for you.
Sure. So I have a lot of patients and a lot of time I got to operate. And that's the toughest part is a lot of what we do, probably 60 to 70% of my practice is cancer reconstruction, majority being breast cancer and skin cancer. And so those can't wait. My wait list for a cosmetic appointment or a cosmetic surgery is several months down the line. I can't ask a cancer patient to wait that long. And so we're constantly fitting people in, adding people in. We have emergency slots for that purpose. So average day for me, get up well before the sun, catch up on paperwork, catch up on any reading I need to, get to the hospital. I operate about 3.5 days a week.
Oh, wow.
So go to the hospital, do a few cases. Normally in the afternoon, I'm seeing patients or doing some skin cancer reconstructions in the office. Wednesdays and Thursdays tend to be my big OR days for my big cases. And then Friday is my big clinic. And I think that's pretty important. I want everyone to feel tucked in and secured going into the weekend. And I want people to go more than a few days after their surgery without seeing me.
Right.
So Friday's a hustle day of, see everyone, make sure everyone feels heard and taken care of.
Right. I remember that.
Right.
So, one of the things that I wanted to ask, okay, so you had said something about taking cancer patients first because of the need. Why is that so important then?
It's a great question. And there's a lot of data out there, both in the breast cancer world and the skin cancer world, that if we wait too long, the cancer can grow.
Okay.
And so early detection is critical in early treatment. And a lot of the larger hospital systems and the cancer societies actually rank their surgical oncologists, medical oncologists, based on time from diagnosis to time to treatment. Patient satisfaction is most closely related to the reconstruction effort. And so while removal of the cancer doesn't depend on my timing, if they want reconstruction, which most patients do,
right,
I have to be able to accommodate that schedule and have surgery for them within a month of their diagnosis with all comers. And so that's where it gets very overwhelming for the patient. They feel a breast mass, they get an ultrasound or a mammogram, they get a biopsy, overwhelming news of hearing the cancer word.
Right.
And then suddenly they've got 5 different appointments with 5 different specialists on different days, and it changes their entire trajectory.
Wow. So I guess the question is now, do you remove the breast too, and then they go through chemo, and then they come back to you to have it replaced, or how does that work?
It's a great question. And it depends on what the patient decides to do.
Mm-hmm.
And so I think backing up just a little bit would be the prudent answer to that question. So after diagnosis, depending on the stage of the cancer, patient has a decision to make. And this happens with their surgical oncologist. And this is going to be predominantly what's called breast conservation or a lumpectomy versus a mastectomy. And depending on the size of the tumor, depending on the location, depending on if, God forbid, there has been spread to lymph nodes, that's what's going to determine if they're going to need chemotherapy, radiation, whether the chemotherapy is going to come before surgery or after. Patient has a tough decision because lumpectomy for a breast cancer tends to be tied with radiation. And the idea of breast conservation is difficult. It sounds great on paper, but in reality, yes, they're having a large portion of their breast removed, and radiation that causes changes to the body. And so it's a tough conversation to have. So I find that even patients that are desiring breast conservation should still meet with a reconstructive surgeon to understand kind of the downstream sequelae of a lumpectomy versus a mastectomy.
So would you mind explaining those two, what a lumpectomy is? And
Absolutely.
'cause not a lot of people know.
Perfect. So let's say you have a small mass, early detection, maybe even a precancer, something called DCIS. A lot of times the surgical oncologist will advocate for what's called a lumpectomy or breast conservation therapy, where they will put in a clip that they can see on imaging. They will go remove probably a golf ball size from the breast,
Okay.
send that to the pathologist to confirm that they have clear margins. Sometimes they do have to go back and take more. That tends to be coupled with radiation afterward. Plastic surgeons aren't normally involved in the front end on that one.
Okay.
On the back end, though, there is always some asymmetry between the breasts after there's removal of a portion and then the radiation occurs, can cause some tightening of the breast tissue. And so a few months down the line, a reconstructive surgeon could offer a bilateral lift or a reduction to make the breast match afterwards.
Gotcha.
So the conversation between the lumpectomy and mastectomy, which is also a treatment for even one of those early cancers, really tends to be patient and surgical oncologist preference. Sometimes based on the type of cancer, they may choose, or the surgical oncologist may recommend, a prophylactic mastectomy on the other side. I do find a lot of patients choose a bilateral so that they never have to hear the breast cancer word again.
Right. Because, I mean, that's one of the biggest things. So going with the breast cancer part of it, do they find that a lot of times it starts with one and then it does go to the other one, or?
It can, not so much a spread, but more of a propensity to occurring. So if the patient has what's called lobular cancer, or LCIS, it has an increased risk of showing up on the other side just based on the patient's genetic makeup. So even if they decide on a unilateral, they have a very high chance of developing something on the other side. And so a lot of times they will be recommended to have a bilateral mastectomy.
So there's different types of breast cancer?
There are multiple types of breast
Really?
cancer. The two most common are going to be your ductal and your lobular, whether it's...
So many medical terms.
Yeah, exactly. So in the breast, you have the glandular tissue. Kind of think of it like some grapes. And
See, I just thought all breast cancer was the same.
Sure.
You know?
They're not, and they're treated differently. And we haven't even gotten into the hormonally sensitive ones yet. And so this is where the chemotherapy comes in, and having a good medical oncologist. Some tumors are hormone sensitive, and so they'll react differently to different medications. And so you can kind of pre-treat the patient sometimes to shrink the tumor so they need less surgery.
Wow, that's insane. I always thought that, okay, when you hear people say, I got breast cancer, I always assumed it was just the same type of thing. Like I know and now I know there's differences as far as skin cancer too, because I know I had melanoma, and I had it twice, and this was over 20-some years ago. And all they did was just cut it out. I had a big piece of skin. I got lucky. They caught it early. However, I remember my grandmother had gotten basal on her face, and they cut it out. It's horrible. I've heard, because like some people I know have gotten melanoma on their face, and it's very hard because there's not a whole lot of skin to take off the face.
Do a lot of that.
So, so you do a lot of that too? So, that is kind of crazy because like, when, like that is hard to like, I guess because they want to go so deep. I remember when I had melanoma and the piece of skin that they took off of me, it was this big. It was huge, and they went deep. I think they all went all the way down to get everything out. Luckily it was cleared. So I didn't need radiation. I didn't need anything else. Goes back to the early detection.
Absolutely.
Right? Because it was on my back. And if my ex-wife, if she didn't have said, hey, you need to go check that out, because I would have never known. And that's just kind of crazy. I mean, when I was going through that process, I went in and first I showed it to my primary doctor, and they're like, doesn't look like much, right? But we'll send you to the oncologist or the dermatologist, and we'll go to the dermatologist. Went to the dermatologist, same thing. Dermatologist said the exact same thing. This is so long ago. I didn't even know. I never even heard of skin cancer. And so I went to the dermatologist, had this mole on my back. They biopsied it, and they said, yeah, you have melanoma. And of course, back then, I mean, I guess it was just different. I don't know. But like, my doctor really didn't explain it to me. And of course, this is right when, the internet started getting hot and everything else. WebMD got hot, and I'm sitting there and I start searching melanoma, and I'm like, great, I'm dead in 6 months, because once it gets into your bloodstream and starts attacking your lungs and everything, your other vital organs. But if you catch it early enough, you can cut it out without the radiation and everything else. He didn't tell me that.
Right.
So here I am freaking out about it, and but it happened twice, and so with that, I mean, I've been through that part of the cancer process. It was quite scary, and then my grandmother, I know she just always spent time in the sun, and then she got basal. I don't know how much of a difference there is with those, but then she had to have that cut off of her face. So it's kind of crazy, like that there's different types. And I don't know if many people knew that. I don't, because people just assume cancer is cancer.
Right.
I mean, when they hear cancer, they just say, oh, but there's different levels. And I didn't even know there's different levels in breast cancer, different things that you can take. I mean, I always hear the horrified stories of, what they've gone through. I mean, I know, it affected my mother. It affected my mother-in-law. It affected my sister. So there's a lot of people that I know that it's affected, whether it was, small or large or whatever, and so, but you always hear the worst.
Sure.
You always hear where they have to have the mastectomy, and then they have to remove everything. And one of the things that doing this as an ambassador for Men Wear Pink, this just isn't just for women.
No.
It's starting to really rise for men.
Correct.
And so can you tell us a little bit about men?
Sure. So breast cancer can occur in men as well, and often, as you said, goes underdetected. I do want to touch on one thing you said, though. Your reaction when you got your diagnosis is something that's so profound, and it changes your whole outlook on everything. The internet is a very scary place, as you've experienced, and without someone to guide you through that, it can take you down the rabbit hole. It took me
down that rabbit hole.
So I think having people to reach out to, support groups, as you've mentioned, these communities that help, is pretty critical. So patients have a network that they can reach out to, and also having a close-knit group of physicians that can spend the time to take them through it. So they don't have the experience where you had, where you get a diagnosis and then it's just kind of left up, well, what happens next?
Right.
So with men tend to be not quite the best patients sometimes. We all think
Yes,
we're invincible
exactly,
and don't really want to go to the doctor and such, and so things get underdiagnosed. So definitely, if there's a strong history, if there's changes within the glandular tissue of the chest, if there's pain, if there's dimpling, if there's any discharge from the nipple, none of these things are normal, especially in a male.
Yeah.
And so it should definitely seek attention.
Okay. Because that's what I was wondering. I was like, how does a man start detecting it? I guess it's just, that kind of stuff, right? So
same as with women. Early detection through self-examination is probably the most critical part. Or if there's a strong family history, early screening.
So when you're self-examining, right, are you just kind of like feeling to see if you feel anything, or?
There are some good guides online on how to do a systematic approach of a self-breast exam for both male and female. But yeah, that's basically it. If you're washing yourself in the shower and you feel something that wasn't there before, a nodule, an area of pain, an indentation in the skin, a tethering of the nipple, or an indentation of the nipple or areola, that is something that should prompt a visit to your primary care at least.
At least to have that conversation.
Sure.
You know, it's kind of crazy because you're talking about men, and men are thick-headed. Um, so I ended up in the hospital 2 years ago. And so we don't always think, oh, we'll be fine. We'll get through this.
Absolutely.
And, you know, it's nothing, you know, and I can, you know, like when I got diagnosed with my melanoma, I mean, I was young. I mean, it was in my 20s. And, you know, so, I mean, I was like, oh, what are you talking about? I was like, I'm still young. I'm not old. One of the other things that I've gotten is, and it does run in my family, is parathyroid disease. So, which is only usually a female thing, and it's usually much older. I had it in my 20s. And so, you know, the thing is that, you know, of course they did some blood work. My calcium was high, and so we started looking at that. And then after figuring all that out, I mean, there's so many things though. But as men, I really do, like, I try to tell people, especially after I gotten sick a couple of years ago, is that, you know, you need to go to the doctors, go get checked out. We do as men think that we're either invincible, or we think that we don't need to get checked out, or I'll be fine. I'll worry about it later, you know, and we don't, you know, because I think the stereotype is that we have to be big and strong.
I agree.
You know, and so, we don't need that. But in reality, we do. I mean, if I'm not and I know it's not that big. I mean, I know prostate cancer is probably the biggest in men as far as cancer. But in women, I'm assuming, I think it's breast cancer, right? Is the biggest cancer. I was actually reading a statistic. I think I saw that in the world, one every 8 seconds, a woman is diagnosed with breast cancer.
Yeah, over 300,000 cases a year.
Yeah, so I mean that's a lot. You know, and so, you know, and then that's why it's so important, and that's why, like, all these, you know, the men wear pink, and then the American, you know, Cancer Society makes a big deal about it, because before we weren't doing this, we weren't checking ourselves, women weren't.
Right.
And I think that's why it's so important that, you know, we make people awareness, you know, and not just for just these two types. There's so many other things that are out there that people don't go get checked, or they don't go get, you know, and that you just never know.
I think you're exactly right. And I think one of the things you touched on, especially with men, is a lot of times we are the provider for our family. At least in my case, that's how it is. You know, my wife takes care of the kids. And we have a subconscious fear of, if I go to the doctor and they find something, well, then I'm going to be out of work, or I'm not going to be able to provide, or how's that going to affect things, or even how am I going to afford medical care? And the counter argument I would make to that is, especially if we look at the survival rate and the treatment for breast cancer, early detection, 99% survival rate, maybe one surgery, and that's it. Late detection, because you've ignored things, let things progress, you're talking about maybe a 27% survival rate and a much larger amount of chemotherapy, radiation, surgery to combat that. And so, to your point exactly of, if something doesn't seem right, go get checked so that you can make sure that you can stay strong and provide what you need to do without that much time off, and that you can be there long enough.
Right. So kind of getting back to what you do, because I know you said, I believe it's like 80, 90% of reconstruction surgery is your business, correct? You know, after these women have gone through this, you know, and I guess the thing is I'm sure this is an emotional thing for them that they're going through, right? You know, especially if they did have the mastectomy, you know, and to rebuild that.
Yeah.
Give us some feedback on what that does for them, because I'm sure that's got to be a huge lift after everything that they've been through.
It is. And it's amazing how far we've progressed in the last 20, 30 years. We used to be very aggressive with the surgical resection of the cancer, the removal of not only the breast, but the breast skin, the nipple, and sometimes even the muscle. And reconstruction was an afterthought. And currently, patients' expectation is that their breast will look better after their mastectomy than before. And they hold us to that. They hold us to expecting a cosmetic result.
Right.
And you're rebuilding an organ that's been removed. So the kind of flow of how things go is they get their diagnosis, they meet with their surgical oncologist, their medical team, they get referred to the plastic surgeon. And I think that's where the first aspect of this is going to be okay comes in, because we are the first to talk about the rebuilding, the restoration, the recovery process, whereas everything prior to our conversation is well, here's how we need to tear things down. Here's what we need to do to remove the cancer.
Right.
And so a lot of patients come into the consultation. We book an hour for our breast cancer consultations because I think it's important that they understand all their options. They come in and it's the first time that they actually have some hope that there is a future after mastectomy. We coordinate with the general surgeon, the mastectomy surgeon, so that often we're there at the same time.
Okay.
The plastic surgeon marks the patient as to what the incision should be. Your general surgeon removes the breast tissue as they see fit to remove the cancer, potentially a lymph node or so. And then a lot of times we can even do what's called a direct implant reconstruction. And so we take a breast implant, wrap it into what's called an internal bra, exactly like an external bra would be,
Okay.
but it supports the weight of the implant. And now we're really trying to put that right where the breast tissue was at the time of surgery. So the patient goes to sleep, has their mastectomy, wakes up looking like they had a breast augmentation. And I think that's
I didn't
really
realize
the
that was
best result.
all that way. Yeah, because I always assumed that they did the mastectomy, and then later on down the road they came back to have that.
And sometimes that is how it goes, but I do find that patient satisfaction tends to be better when they go to sleep with breasts and they wake up with breasts.
Yeah.
And they don't really have the emotional aspect of seeing themselves without. And it also, if we can do it in 1 or 2 steps, saves them a lot of extra surgery and a lot of extra time. As it is, they're going to spend probably half the year having medical appointments and follow-ups and scans and potentially hormone therapy afterward. And so that's a lot of investment from the patient.
You were talking about a hormonal part of it before, and you just brought it up again. Tell us a little bit about that, because that sounds like that must be something that's important with all this.
It is. And so when we talked about there's the different types of cancer, the next thing they're going to do after they establish the type is send it for screening at the pathologist to see if it's a hormone-sensitive tumor. And so the big ones they're looking at are HER, ER, and PR. And depending on its response to those hormone receptors, there are different adjuncts, different medications that can be given to kind of prevent or control or shrink the tumor. And it also gives you a different prognosis depending on how many receptors, positive or negative, you are.
Wow, there's so much that goes into it you don't even realize.
And that's why you need a team. Right?
Yeah, because I mean, I'm sure now nerves and all that, and does that all have to
It's
be
a great question
reconstructed
too. So with a standard mastectomy, yes, the nerves are removed. And so the breast tissue, and if we do a nipple sparing, even the nipple is numb afterward. Some of the more evolving techniques right now that are on the forefront of my world are actually nerve reconstruction. And so we've talked a little bit about implants. If we want to go the next step in aggressiveness, it's rebuilding the breast with the patient's own tissue. This is what's called autologous tissue, where we use most commonly the belly fat. We take it off from the belly and install it up here. It's microsurgery. It is a long case, but we can often do a nerve reconstruction at that time so that we can provide sensation to the breast and sensation to the nipple.
I was wondering about that. I was wondering if it's all completely gone, you just put one there, do they feel anything?
Not normally.
Not normally. Then see, another thing that it's kind of crazy how much you can learn from all this, and that you never knew unless you've been through that. I mean, you know.
Yeah.
Because I was wondering about the nerves because of my arm, obviously. I was thinking about the nerves in my arm. And like I was sitting there thinking, I was like, okay, well, do they feel anything? I mean, so, but now the technology is coming there to even replace some of that.
That is the forefront. The other thing that is the current cutting edge is, instead of being reactive, which medicine in this country does tend to be pretty reactive, we wait till we're sick, then we treat rather than prevention.
Right.
Lymphedema comes along with breast cancer. And so often during a mastectomy, they'll remove what's called the sentinel node, just as a spot check to see if the cancer has moved from the breast to the lymph node.
Gotcha.
That has a small risk of lymphedema. Sometimes if more nodes are involved, they'll actually remove all the lymph nodes from under the arm. That puts the patient at a much higher risk of lymphedema. Now, lymphedema is fluid that doesn't return from the arm, right? Your artery brings it down, your vein brings it back, but some of the fluid leaks out. That fluid that leaks out tends to stay there and can lead to issues. So historically, we've been reactive about this and put the patient into physical therapy, compression garments, or at late stage done free tissue transfers. Now we're even doing lymphovenous anastomosis, so connecting the lymph vessels after the dissection to a vein during the mastectomy to prevent lymphedema. So again, going back to how much we've advanced in the last 20 years, where we're at with preventing future issues, complications, complaints with the nerve reconstruction, with the lymphovenous reconstruction, with the autologous tissue, it really is a new world for reconstruction.
So the lymph nodes, they're under in the armpit, right?
They are.
Yeah. So tell us about that, because like I know what they kind of are, but I don't know enough.
Sure. So you have lymph nodes all throughout your body. There are basins where there's a lot of them deposited. Kind of your groin, your armpits tend to be the major ones.
Now, sorry, I don't want to cut you off, but is like now the lymph nodes, because I remember them talking to me about it when I had melanoma.
Yeah.
Now, is that the majority where you get your cancer, or?
So it tends to be, it's the toll booth on the highway.
Okay.
And so when your cells are doing what your cells do, or your tumor cells are doing what they do, some of those byproducts or the cells themselves get carried along within the lymph fluid and brought back into your central system. Well, on the way, they stop at the toll booth. The toll booth is the lymph node. This is why when you get sick with the cold, your lymph nodes get larger, because they found particles of a virus and they're reacting to it. With cancer, it's no different. And so your lymph nodes are the first sign of, hey, something's not right. And so they will catch these particles and they'll get stuck within the lymph node.
Okay.
What this tells us is not that the lymph node itself is diseased, but that the tumor has kind of crossed a membrane or a barrier that we didn't want it to, and has spread beyond the organ that it's in, and potentially has spread throughout the body. Now, it's easiest to check the lymph node because it's right there and we know that's where it goes first. But if we do have a clinically positive node, or microscopically, it does change the treatment, and that's when chemotherapy becomes involved, because then we need to treat the entire body and make sure that any cells that have progressed past that toll booth have been stopped.
Okay, so that kind of gives me an idea, because I know that there's lymph nodes in your neck too.
Yeah.
And so I know some of it, but like not a lot.
Right.
But like, because I just, after going through what I've gone through, and so, you know, and I never thought about, I didn't know like that's how the stuff gets around. So basically what happens is, if they gets past your lymph nodes and gets into your other body, then that's why you need the radiation to try to kill all that. Chemotherapy.
So radiation is site specific.
Okay.
Sometimes is an alternative or an adjunct to treat the locally invasive disease at the site. Chemotherapy is system wide.
Okay.
And so once we've progressed into the whole body, we're going to consider chemotherapy. If we're doing a spot treatment in the area, or we want to treat that area a bit stronger, then we may do surgery plus radiation, or just radiation to the area.
That's crazy. There's so much. There's so much involved in things that you just don't know. But like you said, it's very important to have that early detection, have those tests.
Oh, absolutely.
You know, I mean, I think they say that you should at least have, you know, women, you know, I don't know about men, but at least women go at least every year to get, you know, checked up on, just to make sure.
Absolutely. And as I mentioned earlier, we are seeing an increase in prevalence in younger patients. And unfortunately, I'm seeing that in my practice as well. So while the guidelines are optional mammograms at 40, required mammograms yearly at 45, in my practice, anyone that's getting breast surgery, we start at 35. And if they have a family history, we start younger than that. Reason being, I've treated way too many 30-year-olds and even 20-year-olds with breast cancer.
Why do you think that is?
It's a great question that I don't have an answer to. I mean, that's a deep rabbit hole to go down of our food or our genetics or our exposure to things in the environment. I don't have a good answer for that.
For that one, yeah. I was just curious because, like, I mean, we always heard it was usually the older women who got breast cancer.
Yeah.
But now you're starting to see it in the younger people. And I knew some people that gotten it in their 20s and 30s, and, and it's kind of devastating because they always thought it was usually, and that's why they don't check, is because it was I hate to say the word old lady,
Sure.
disease or something like that. That's what they assumed. Oh, I don't have to worry about that until I'm in my 40s. Sort of like even men, where they say, like, I think you got to be like 45 or later for prostate cancer, even though we're seeing it even with younger guys as well in that. Because it's critical, I think, I mean, especially family history. I mean, it's part of what I was told when I had melanoma and even when I had my parathyroid was family history. And so
I think you make a good point. And especially with a younger patient, you have a 25 to a 35-year-old who feels something in their breast that doesn't feel quite normal. Most commonly, that's going to be a benign fibroadenoma or a cyst. They go to their primary care, their OB-GYN. It may be dismissed as, you're a 20-year-old, 30-year-old, you're not going to have breast cancer. Well, being an advocate for yourself, if you don't think that that is right, if you have symptoms that aren't addressed, be an advocate. Find a practitioner that will order an ultrasound for you or will do a biopsy for you and kind of push. There's been way too many cases where something like that has happened and it's not detected till it's too late.
And that's what a friend of mine, I think his wife was about 28 or 29, didn't have the test done, and then passed away from it because she just never thought it would happen to her because she was so young, and it was just kind of devastating. He was devastated, and obviously, I mean, what he went through and saw, and because you just don't think about it. You don't think about it at that age. I mean, it's always a much older problem, it's not going to happen to me until I'm older. Well, here we are. We're seeing things change, and can't be specific about what our environment is doing or what we're eating and processed foods and whatever that may be causing this to start coming out sooner. Yeah. But we're definitely seeing a change in the younger generation where they're not paying as much of attention to their bodies, and they don't want, they don't go check out. They don't go to the doctors. I mean, I know I have two boys and a 30-year-old and a 27-year-old, and I know both of them are just ignorant. I hate to say the word, but I know they don't go to the doctors like they should. Right. And so they're hard-headed and they're hard-headed boys and, but after they've seen what Dad is going through, they've kind of opened up a little bit more about it. Right. But it is something that I think that, and I remember when I was in my 20s, I thought I was invincible. It's not until you start getting older and you start going, okay, something doesn't feel right, or you start feeling older or whatever, and you start taking things more seriously than you did when you were in your 20s, especially when I was in my early 20s. I didn't think anything was going to happen to me. Of course. And so, it's just kind of sad that you're starting to see more and more of this, and it could have been prevented if we would have checked it early and we could have gotten to it, or just, I mean, I was very fortunate with my melanoma that we caught it early because, it could have been a lot worse. And it could have, I was, like I said, I went on the internet and went down that rabbit hole, and I was like sitting there thinking, I was like, I wasn't going to see my kids get married. I wasn't going to see any grandkids. I didn't know what was going to happen. And so and it was just because of the early detection that
course,
saved my
critical.
life. And so, you do want to get out there and get that done and get it checked. And I think it's great that we've made it such a big thing about getting, tested and raising awareness about it. I mean, there's so many things that are going on now with men helping, even getting the word out to women with the Men Wear Pink and all these, the races that they do and the charity events that they do. I mean, just from, Men Wear Pink part of it that I am in, there's 27 guys that are all trying to raise money in this, small little, area. And we're all doing different activities for it, all trying to raise awareness, trying to collect money to help fight this. But I really think it's not, I mean, the money helps, but I think it's more about the raising the awareness.
That's correct. It's the talking about it.
And I think so many people, they used to call it, where you don't talk, like you don't want to, I forgot the name of it, but basically where you don't want to talk about it, or it's not, you don't want to bring it up. And because it's taboo, that's the word I was looking for. And, because if you don't talk about it, then it's not existent, and I think so many people sit there and it's not going to happen to me if I don't talk about it.
Also true. But with 1 in 8 women being affected, everyone knows someone or has someone in their family, everyone. And so bringing up the conversation openly will create that conversation, create that awareness, and may prompt someone who's been thinking about it or felt something to go get checked and have a much better result because of it.
I think that's what's been great about all this is the campaigns of everything, because I do think that you're starting to see more and more women really get comfortable with it and talking about it. I went to a major event where for the American Cancer Society, where they talked about the breast cancer, and they had all these survivors there, and brought all these different people there and all these different women to talk about it. And and the thing is it was just very eye-opening. It was very joyful but sad at the same time, right? You see these women that have gone through this. I mean, some of them have gone through it pretty badly.
Sure.
And the stories that you heard. But I think that there's more open dialogue about it now. I think there's more open dialogue about cancer, period, now than there ever has been.
Yeah.
People are talking about it. They're talking about going and getting tested. They're talking about going and talking to somebody, because, like you said, one out of every 8 people, we know somebody's been affected by it, right? So the thing is like, you could still have that conversation with that person, or you could still like, wow, I never realized, there's so many people that I know that in a small circle that have been somewhat affected. Some of them, they caught it way early and didn't have to do hardly anything, or it's been, they caught it almost too late, or they did catch it too late. So I think this is a great thing. I think it's a great thing that what you do, I think is very important, because I know, a lot of women that I've talked to, and, their self-confidence goes away when they've had that mastectomy.
Sure.
And, they don't feel like they're a woman again. I mean, or they felt like it's been taken away from them. So I know that that's very important, and to give them the life and hope back that they had once had.
Right.
So.
Right. I mean, that's the hallmark of plastic surgery, is restoring form and function and giving them that confidence back and that life back that they were worried that they were going to lose. And if we can do it sooner than later, I think it's even better.
Right.
Having access to care is another critical part. And so knowing that there are surgeons in the area, and there are several good surgeons, myself included, in this area, that offer these advanced techniques. And so as long as patients talk about it, find someone that can help them,
right,
we can hopefully restore that for them.
So, do you have anything else you want to add into this?
No, I think you've done a great job. I think that raising the awareness is fantastic, and I appreciate you having me here to talk about these things, and so hopefully people have a better understanding. I see a big shift in, you talked about the newer generation, in preventative medicine rather than reactive medicine. The current request from patients, the current feel I get is, how can I be a healthier individual? Cancer aside, but what can I do to improve my life, right? How can I be around longer? How can I improve my cognition, my performance, how I feel? No one wants to be sick.
No.
Right? No one wants to go through these things. And so if we can keep ourselves healthier, we can prevent a lot of these issues.
Yeah, I think there's raising the awareness about all this and raising that part of it. A healthier lifestyle, whether you're going to the gym or whether you're walking, whether you're just getting out of the house and doing something. I think that a lot of people don't realize how important that is. I don't think people realize how just being active is, and getting out there, eating healthier. A lot of things. We have, as Americans, have so many choices, and just that are out there. And yeah, it's hard to not want to go socially drink with your friends all the time, or do things that aren't always the best for us.
Right.
And so, it's hard to kind of have that balance in life. But the thing is that what we're seeing is, if we don't have that active lifestyle, or we don't add some kind of fitness or eating healthy into our lives, then I think, and I don't know how much truth there is into this, but we do seem to see where people are living longer and being healthier with a healthier lifestyle.
I agree.
So, and I'll get off my soapbox about that, because, both of us like to go to the gym and eat clean.
At 5 in the morning.
So, but, basically that's one of the things that I do see that is up and coming. I do see a lot more younger people going to the gym. One of the things that always makes me happy when I do go to the gym is I see people, that are younger, who are overweight, and they're trying. At least they're out there and they're trying to do something. You can never disrespect somebody who, okay, yeah, whatever happened in the past, but at least now they're trying to fix it. And so, that is heartwarming to see when you see a 300-pound person, or, somebody who's, like that is in the gym, is trying to eat clean, trying to get healthy, and change their lives. A lot of times I think, just from what I've seen in the past, in the years, we get a lot from our parents. Fair. And we kind of follow our parents' habits. And so, and if they didn't eat clean, they didn't do whatever they did, unfortunately, I was not going to be a statistic, because in my household, it was very much like that. Fast food all the time, going out to eat all the time. Both parents smoked, and unfortunately I lost my mother at 62 because of that. And I was like, well, I'm not going to be another statistic like that. I'm going to be healthy. I'm going to eat. Granted, I could get hit by a bus tomorrow. I'm not going to would. But the thing is like, I do believe that is a part of it. So thank you for coming on. I appreciate it. I appreciate the awareness of it. I thought it was very important to have somebody to come and talk more about it, especially since this is Breast Cancer Awareness Month. And I know that with what you do and the help that you help people, give them hope, is very important. So I wanted to thank you.
Yeah, absolutely. Thanks.
All right, guys, that completes our podcast. So make sure, if you're wherever you're watching, you subscribe. We're on YouTube, every platform that you can think of. And again, if you would like to make a donation, I am going to have the link for my ambassador program, so you can actually make a donation. Even if it's $1, $2, it doesn't matter. Whatever you can help contribute will help this, fight this disease and help other people get healthy. Thanks so much.